We will not be ready for any surprises in the operation room. We don't want any surprises in the operation room. We have to be clear about what we understand about the patient. So we will order something called a CT scan of the temporal bone. So what we do a high resolution CT scan of the temporal bone. It's called an HRCT temporal bone. You can do it on one side. We prefer to do both sides so that we can compare. Like I said, it's very important. Suppose a patient does not have significant disease in the mastoid, but congenitally he has aplastic mastoids. So if you are comparing with the opposite side, then only you will be able to know. The other side, the eardrum is fine, does not have any history of otitis media, no discharge, nothing. Still the mastoid is sclerosed. So this is probably something he has by birth. He does not have a pneumatized mastoid. That is fine. Some people may have a sclerotic mastoid or a shrunken mastoid. And some people will have a very nice pneumatic mastoid. So that's why we do a HRCT temporal bone comparing both the sides. And in a CT scan, obviously, what we can also assess is the status of the tegmen plate, that is the dural plate, and the sinus plate. What is sinus plate? It is the thin layer of bone that covers the sigmoid sinus. Okay, so I have drawn this picture. So if you see, so here we have the dura and the brain, and this side we have the sigmoid sinus. Okay, so on X-ray or CT scan, we should be able to understand how much we need to operate, where we need to stop, and so that we do not injure the dura or do not open up the sigmoid plate and injure the sigmoid sinus. So the things that we need to know is the status of the mastoidal cells, the tegmen plate or the dural plate, the sinodural angle, that is the angle between the tegmen or the tegmen tympani and the dural plate and sinus plate, and the status of the whatever. These three things we need to see very clearly on an X-ray. But when we are hiking up to do a CT scan, we can get a lot more informations. What? We can see the status of the ossicles. We can see whether they're intact, where they're eroded, is there any soft tissue opacity in the mastoidal cells, what is the status of the scutum. Okay, all these things we can easily make out. So if there is something, if any symptom is not matching with your finding of a central perforation, we sometimes need to hike up the investigation to see if something else is there or not. A CT scan will give a clearer picture of the sinus plate, the dural plate, the tegmen, the ear ossicles, maybe the position of the semicircular canals or the inner ear. Everything will have a much clearer idea. Okay, so in case of central perforation where there are complications or something like that, we usually hike up. So another important investigation, so this is the radiological investigation, CT scan or X-ray. MRI we normally never do for chronic otitis media. Don't utter the word MRI unless it is something related to the inner ear. If there is any disease related to the inner ear, if you are asked about investigations, go for, you may say MRI, but not for middle ear or external ear. We usually do not do. Okay, so next comes audiological evaluation. This is very, very important. So you have done a Rini, a Weber, absolute bone conduction test on your examination, right? So from that you have got an idea whether the patient has a hearing loss, whether it is a conductive loss or a sensorineural loss or something like that. But before going for a treatment, before going for a surgery or something like that, we have to be sure, or we have to evaluate how much the loss is. For example, a patient has come to you with a 50 decibel hearing threshold. Okay, so you have done a surgery. Will it go back to normal? There is a chance, but it may not always. It may improve, but it may not always go back to normal. The patient, if you have not done a pre-op PTA, pre-optal audiometry pre-op, the patient may come to you and ask you, doctor, you said the hearing will improve, but still now I have a 40 decibel, 30 decibel loss. So, it is very important to compare the pre-op hearing status and the post-op hearing status, both medically and medico-legally. Okay? And, for example, you are seeing a small perforation. You are planning a tympanoplasty. We call it a tympanoplasty. So, normally for a central perforation, we do something called a type 1 tympanoplasty or a myringoplasty. Okay? When we discuss about surgeries, we will discuss in details again about the different types of your surgeries, because you need to know type 1, type 2, type 3, type 4 tympanoplasties. Okay, what is mastoid surgery, what are the types of mastoid surgery, like what is a cortical mastoid surgery, what is a modified radical mastoid surgeries. So all these things you need to know, at least the definitions. You are not expected to understand everything and all, but at least know the basic things so that you can answer a few words when asked about the surgeries. Okay, so that would be most of it for the ear case. I'll start with the history taking of a nasal case today. We'll do some basics. Okay, একটু খালি রাখ. We may add a few points here and there later on. Okay, কে বলবি? Someone volunteer. So like I said, the most common nose case that will be given to you will be a deviated nasal septum, DNS. Okay, or sometimes, very rarely, if we have something like a gross nasal polyp or antrogonal polyp or something like that, we can give as a long case, but most of the times it's a deviated nasal septum. Okay, so say your long case is a deviated nasal septum. So how will you start? What are the chief complaints in a deviated nasal septum? So the primary complaint almost always is nasal obstruction, and it is usually unilateral nasal obstruction. Can it be bilateral? So sometimes it can also be bilateral. So you need to ask the patient clearly, এক নাকই বন্ধ থাকে না দু নাকটাই বন্ধ থাকে? It is usually unilateral, but sometimes there is something called a paradoxical obstruction. It can be bilateral also. I will explain you why. I will show you why. Okay, so the patient usually presents with an unilateral nasal obstruction for a certain period of time. So how long will that be? It is not an acute disease, it's a chronic disease. Unless preceded by some trauma or something like that, it is usually a chronic disease. Okay, so suppose a 16-year, say a 15-year-old male has come to you with unilateral nasal obstruction. You have diagnosed this case to be a deviated nasal septum. That is the thing. So see, septal deviation is a developmental process, right? So we have to make sure always that the growth is complete before we touch the septum. It is very important, unless it is so severe so as to cause severe problems. Apart from that, so what I ask this because I want you to understand, see, deviated nasal septum is a chronic disease and it's a developmental disease. So over time, when the body has developed, when the nose has developed, it has, with growth over time, there has been a deviation of the either the bony or the cartilaginous part of the septum. Okay, so the symptoms are almost always insidious onset. It is never acute onset. Suddenly from today morning I cannot breathe well on my right side, so it is a DNS. Cannot be. There has to be something else then. So DNS patients, primarily, if the disease is a deviated nasal septum, will complain of nasal obstruction probably for quite some time, maybe a few years, sometimes a few months if young patients, but most of the times it's a few years. Okay, what other symptoms can be there? Epistaxis, very good. Why is there epistaxis? So what happens is say this is the nose. This is supposed to be the septum, and we have the turbinates on each side. Okay, so this is the ideal scenario. We have the septum in the midline, inferior turbinates, middle turbinates, and superior turbinates on either side. So now, say this is not this. The patient has a deviated septum like this. Okay, so what will happen? So if you try to understand the pathology, what happens is there will be decreased airflow on this side and increased airflow on this side. Right? So what will happen? There will be, if there is more air than the body can handle, the body will always try to decrease the increased air entry on that side. They will try to do something so that so much of dry air doesn't go in. Because the more the air goes in, okay, পরের দিনের জন্য তাড়াতাড়ি চলে এসেছিস। So there is increased air entry on one side. Okay, so the body will automatically try to adjust that. It always does. So if there is any problem in the body, the first thing that the body does is try to adjust it by itself. If it cannot, then we usually seek medical help. So what will it do? It will do two things. First, it will gradually try to increase the size of the turbinates. So there will be a hypertrophy of the turbinates. তাহলে কি হবে? আবার এখানে এয়ার এন্ট্রিটা সেই কমে যাবে। So it's a compensatory hypertrophy of the turbinates on the opposite side. This is the reason some DNS patients may also say, I have obstruction on both the sides. একদিক থেকে তো নিঃশ্বাস নিতে পাচ্ছিলামই না, there was a gross deviation. So now the body trying to correct it have got me something called the turbinate hypertrophy, so that I am not able to breathe through this nostril as well. This is what is called the paradoxical obstruction. Okay, or sometimes there is another thing that can happen. If there is increased airflow, the laminar nature, so like when we are breathing in, the air is going like this to the airway. So there is always a smooth laminar airflow through the nasal cavity into the nasopharynx. But if there is sudden increase in the amount of air going through that nose, that laminar airflow pattern will be altered. So there will be turbulence. So if there is turbulence, there will be obstruction. The feeling of obstruction will be there. Okay, so these two reasons are there why some patients still can say that we have bilateral obstruction. Okay, so next is epistaxis. Why there is epistaxis? For example, like he said, there is a septal spa. So there are two main reasons for having an epistaxis. One is, like I said, there is increased airflow or alteration in the laminar airflow. This will lead to formation of crusts in the nose. So the mucus or the nasal secretions, they are unable to drain properly. So they will dry up. So the more the secretions dry up, there will be formation of crusts. And when these crusts are dislodged from their places, they'll cause bleeding. So the patient will have epistaxis. Another thing is, like he said, when there is a, for example, say the deviation is not like this. The deviation is like this. Many a times we see a sharp septal spur. So when there is a sharp septal spur, it can either impinge on the turbinate. So the mucosa over this spur will be very stretched out and thin. So the blood vessels are also stretched out and thin. So a minor crusting or minor trauma or maybe a minor dryness can cause those capillaries of the blood vessels to, rupture and cause bleeding. So epistaxis. So right now we have a patient planned for surgery recently. So that patient is a young female, has a very bad septal spar causing repeated epistaxis. Yes, she has come to the emergency 2 to 3 times and is planned for surgery in a few days. So that is the reason this DNS patients will have epistaxis. Okay, but it is usually off and on, not always very severe. It's usually mild to moderate in amount. Okay, so what is the other things that the patient may have? Headache, very, very good. So, two chief complaints are always there. One is nasal obstruction. Epistaxis may or may not be there, but most of the times headache will be there. Okay, so a deviated nasal septum can cause an alteration of, like I said, there will be turbulence of airflow in the nose that can give rise to headache, or this kind of deviated septum impinging on something else may cause neural stimulation and cause pain which can be radiated. So the patient may have headache. What else can be the causes of headache? Well, ঠিক আছে তো হলো বললাম তো neural stimulation. What else can be there? So suppose the patient is having a DNS, right? So there is obstruction, nasal obstruction. So there is decreased sinus secretion clearance on that side. So sinus secretions are not coming out properly. So there is persistent collection of the sinus mucus secretions within the sinuses that can give rise to sinusitis. The patient, very commonly DNS patients present with chronic sinusitis causing headache, particularly when the ethmoid sinuses, the frontal sinuses or the sphenoid sinuses are involved. Maxillary sinusitis are usually present with heaviness in the maxillary region or maybe pain at times. But ethmoid sinusitis, frontal sinusitis can mimic headache. I mean, it can give rise to headache. Okay. So these are the chief complaints. So history of present illness, like I said, will be elaboration of the chief complaints. Similarly, like we did in the ear case. So obstruction started from these many days. Will it be progressive? Will it be progressive? Achha? Yeah, it's usually so slow. The changes are so slow. Patient usually will not appreciate a typical progressive kind of obstruction. But what what the patients usually say is, whenever I catch a cold, it's completely obstructed. যখন একটু ঠান্ডা লাগে, একটু সর্দি হয়, একদম নাক বন্ধ হয়ে যায়, cannot breathe. So earlier it used to happen off and on, but it was not this severe. So nowadays, whenever I catch cold, it is so bad that I get a complete obstruction of my nose and I have to breathe through my mouth. Okay. So since this is, like I said, it's a developmental thing, it has not happened overnight. So the body gets adjusted to it. So it's not like it's a progressive disease. No, after the age of 18 years, there's hardly any further growth of the bony skeleton or the cartilaginous framework. Okay, so the chances of the progression of the DNS is very less, but there can be complications which can cause symptoms. So if there is a URTI, increased nasal secretion, associated sinusitis, or blockage of nose, maybe mucosal edema of the nose, nasal mucosa causing obstruction. So patients will say that off and on when I have cold, I have a gross obstruction. So aggravating factors, URTI, okay, any nasal irritants, allergic symptoms, these things can aggravate the symptoms of a DNS. Relieving factors are mostly decongestants, nasal decongestants. When used, medication symptomatic can cause decongestion of the nose and can give a brief relief of the symptoms. Okay, coming to epistaxis, again, dry weather is a very important aggravating factor, or exposure to heat too much, like working, those people who are working in dry weather outside for a long period of time, okay, maybe, or lives in very harsh environments like very extreme cold or something, can have repeated epistaxis in DNS. So it is important that you ask these questions to the patient. Okay. Progression epistaxis, yeah, epistaxis can worsen with time. So more this mucosa gets dried up, the more it can have repeated epistaxis. Initially starts as one episode, but over time the frequency of the episodes may increase, and the patient may have significant number of episodes of epistaxis, causing him to consult you. Okay. Headache. How will be the nature of the headache? So in DNS, what? Huh? Hmm. Now, what is the character of the headache? How will the headache be? How will the patient tell you? How will you differentiate from other types of headache? The patient may, I mean, a patient may have an associated migraine. Very common. So DNS patients can have unilateral headache as well. Pulsatile, it's not pulsatile, it's throbbing. The word is throbbing. Okay. So see, the DNS patients, it's usually very persistent. It does not, like, for example, if the patient is having a complication or say a migraine or something like that, any other disease associated, the nature of the headache, for example, like he said, in a migraine, it will be unilateral throbbing headache. Okay, that's a typical character of the migraine headache. But usually, DNS kind of headaches are dull aching headache. It is very persistent. It is a boring pain. Okay, it can be worse mostly in the morning when there is, as I said, because the patient lies down. So they have been collected sinus secretions, can worsen the headache. So it's usually you cannot find a fixed nature of the headache that specifically depicts ke this is only because of DNS. Nothing like that. But like he said, it's a neural headache. The nerves are stimulated, so it can be sometimes a very sharp pain. Okay. So chief complaints done. History of present illness, almost like that. Aggravating factors, relieving factors, I told you. Okay. So next, family history. Any role of family history in DNS? Not much. Okay. So family history is usually many a times, sometimes, yeah. The patient may give history of a sibling or parents having a surgery for deviated nasal septum, but not always. It's not always there. Okay. The next would be social history. Any relation to social history? Smoking, drinking, anything? It's a developmental disease, so no, there will not be. Okay. But then again, exposures, if the patient has associated allergic symptoms, exposure to fumes, exposure to allergens can worsen the symptoms. Okay. Tarpar? Examination. आगे कुछ स्पेशलिस्ट होंगे हाँ आगे देख भी ना तो what are the steps of examination? External examination, right? I am not going through general examination. You all know that. Last day everyone told me cut. Very nice. So local examination will start. Local examination, first is examination of the external framework of the nose. Okay. So a DNS may or may not be associated with external deviation. Okay. Many a times a patient comes to us and says, "Doctor, I have a deviated septum." So when we explain the surgery or something like that, they tell us, "So ये जो बाहर वाला जो टेढ़ा है ये ठीक हो जाएगा ना?" No. Both are completely different things. A deviation of the external framework needs something called a rhinoplasty. It's a different thing. It's a cosmetic surgery. And septum is something different. We call it septoplasty or SMR, whatever. Depending on the nature of the surgery, there are different kinds of surgeries, whatever. So External deformity may be there, may not be there in a deviated nasal septum. If it is there, then while performing the surgery, we prefer to correct both the septum and the external framework. But if it is not there, we do the septum only. Okay, if the patient needs a surgery first. Then next is, so deviation chhada or external framework, what else will you see? Oh, that's AR, anterior rhinoscopy. What from outside will you see? The skin. কি কি থাকতে পারে স্কিনে? What else? Name a few diseases of the skin of the nose. এগুলো পড়বি. So there are multiple diseases of the skin of the nose, rhinopyma and all those things. Some sebaceous hypertrophy, skin changes will be there. There can be ulcers. There can be, basal cell carcinoma arising from the nose. So many things are there. So just mention that the external skin is normal. If it is normal, if there is any scar or anything in that, please mention that. Okay. And then coming to, okay, এখন এসছে হ্যাঁ আচ্ছা. So the next thing would be examination of the vestibule of the nose. Before rhinoscopy, always examine the vestibule of the nose, because when doing an anterior rhinoscopy, we usually put in a speculum. Right? What is the name of the speculum? Have you seen it? Something that starts with T. It's called the Thudicum nasal speculum. I'll show you. When we do the instruments, I'll definitely show you. It's also there in the OPD. We can show you there. So the speculum has two blades. It's used for anterior rhinoscopy to examine the nose. So if you put the blades in, we will not be able to examine the vestibule. So before the anterior rhinoscopy, it is important that you examine the vestibule properly. So you can just lift the nose up, examine the vestibule and the anteriormost part of the septum of the nose. What all things can happen here? There can be folliculitis. Okay, there can be ulcers, granulomatous ulcers. Okay, all these things can be there. Then we do something called an anterior rhinoscopy. So the third is anterior rhinoscopy. What instrument do we use here? We use something called a Thudicum nasal speculum. Thudicum. Thudicum nasal speculum. So it is like a speculum. We usually sit in front of the patient. For examination purpose, we will always say we use something called a Bull's lamp or a headlight. Okay. So what we do? We hold the Thudicum speculum in the left hand. We put it inside the nose, open up and examine the nose. What structures do we see? ঠিক থাকবে বল ফার্স্টে সবচেয়ে কি দেখবি আগে সেপ্টাম দেখবি okay so you're examining always write septum first you're examining a case of DNS so most of the cases that we will give you will have a gross deviation obviously so right the septum is deviated to this and this side okay associated with a spar or not associated with a spar whether if there is a so how we write there is an S-shaped deviation okay or there is an anterior deviation to the right with a posterior deviation to the left sometimes or there is a gross deviation to the right side of the nose okay whatever it is right like that and if you can see any specific spar so spar like when we examine the nose when you come to the OPD we can show you so many patients come so sometimes there can be a smooth deviation like the entire septum is deviated to one side or sometimes there can be a slight deviation to one side and there will be a something projected out like I drew in that picture na? Okay so that is called a spar. A spar is a sharp projection from the septum. So if there is a sharp projection from the septum sometimes you can appreciate it or anterior rhinoscopy. So if you can see it write it down so there is a sharp spar projecting from the inferior part of the septum or the superior or the upper part of the septum which may or may not be impinging the turbinate. Whatever you see, right? If you can see that the spar is touching the turbinate, right? If you cannot see the spar touching the turbinate, you just write that there is a spar. Okay. Then you should mention the status of the inferior turbinates, whether there is a gross hypertrophy of the inferior turbinates. Like I said, there can be a compensatory hypertrophy of the inferior turbinate on the opposite side. So you write down that there is a septal deviation to the left with a spar, this, that, and this is also associated with the hypertrophy of the opposite or the right inferior turbinate. Okay. Then if you can see further, no one, to be honest, expects you to see beyond that in anterior rhinoscopy. Because if there is a DNS, anyways the space is less. And there is an ITH, an inferior turbinate hypertrophy. Even the space is further less on the other side as well. So most of the times we cannot see any further if we don't do a nasal endoscopy. Only if we do a nasal endoscopy, we can see a bit further. We can see everything in details. But sometimes the other side, the opposite side, can be very roomy, can be big. If there is no significant compensatory hypertrophy of the turbinate, and you can very clearly see what's inside. Okay, if you can clearly see the middle turbinate, mention that the middle turbinate or middle meatus as far as visualized is within normal limits. Okay, so if you can see only then write. If you cannot see and still write, the examiner may go through it and may, drill you a lot. So we cannot even see and you could see the middle turbinate and everything. Okay, so see what you write. I write what you see only. Okay, then তারপর কি করবি বলছিলি এক্ষুনি বল cold spatula test. So what is cold spatula test? So what instrument do you use for a cold spatula test? What? It's a tongue depressor. It's a cold tongue or cold or normal temperature tongue depressor. So the air we breathe out is warm. আমরা যেটা নাক দিয়ে ছাড়ছি obviously সেটা গরম compared to the environmental air. So if we place a tongue depressor, the flat part of the tongue depressor below, like here, below the external layers, and we tell the patient to breathe out, you can clearly make out in the side of the obstruction the mist formation will be less, and the other side the mist formation will be more. That means the patient is obviously breathing out more air on the unobstructed side. Okay, that will help you have an idea कि हाँ कितना obstruction सच में है. Okay, so cold spatula test is something that you should write because it is very easily done while examination. Okay, and okay, so it's I mean we can show all this in examinations in the when you come to OPD for clinics. We'll definitely explain all these investigations. Okay, then what else? হয়ে গেল কোল্ড স্প্যাচুলা টেস্ট অবস্ট্রাকশন দেখেছিস টার্মিনেট হাইপারট্রফি দেখেছিস আচ্ছা another thing you should mention in anterior rhinoscopy I missed out the status of the nasal mucosa whether the nasal mucosa is inflamed whether it is so in case of allergic rhinitis how will the mucosa be okay then in case of URTI so in case of any infection it will be red congested okay but in case of allergic rhinitis or any kind of chronic allergic disease it's usually bluish and pale in color because there is edema okay so allergic rhinitis patient the nasal mucosa is usually typically pale bluish in color sometimes there you can also see there is edema involving the middle meatus but in case of infective rhinitis, like say a URTI or something like that, you'll usually get a congested nasal mucosa. Okay. In case of patients having complaints of epistaxis, always mention whether you see any blood clots in the nose or not. Okay, if the patient has epistaxis in the chief complaints, always mention that. No active bleeding, there is no blood clots, or if you see blood clots, you will see that on this side there were blood clots in the nose. Okay. Then what comes after cold spatula test? Always examine for sinus tenderness. That's a part of the examination of the nose. So your examination of the nose is examination of nose and paranasal sinuses. Okay. So when examining the paranasal sinuses, we examine the maxillary sinus tenderness. So we press on the maxillary prominence and see. We press between the eyes on the nasal bridge. We see the ethmoidal sinusitis. For frontal sinuses, we place the floor of the frontal sinus on each side. Okay. Now, if you press too hard, anyone will shout. Okay. So, we have to gently press it. If the patient still complains of pain, that means there is an inflammation going on and probably it's a sinusitis. Okay. What comes next? I think we are good for today because we'll again have to go through the investigations and management. Okay. So once you start, what happens is if you start one thing now, if you complete your ear case, it will be very easy to complete the nose case as well. Because history is almost similar. So ENT, in any ENT examination, there are three main things: the ear, nose, and the throat means mostly tonsils. So nothing else in the throat probably will be given to you as a long case. Even if it is given, it will be a chronic tonsillitis or something like that. So very basic cases. And the history is almost very typical. Almost, it's like maybe the timings, the months or the days may vary, but most of the times the symptoms will be very classical and very typical. So it's not like you have to prepare a lot for it. Okay, it's very basic. So this time also when your seniors were giving exam, I saw a few papers. I mean, they have written everything, but many of them have missed very important points. Don't do that. Since it's very basic, before exam, try writing a few cases off and on. When you get time or when you come to ENT OPD, try writing a case before coming to the OPD. It will take half an hour hardly to write the basic things. You don't have to describe in details, you don't write like an exam, but try to remember the points so you don't miss it. It's very important that you remember all the points. Okay? Okay, next day we'll discuss on the investigations and management of deviated nasal septum.